Dr. Serrato, how can you describe uncontrolled diabetes affect your joints or your bones?
Oftentimes, if you're having to see me, then something went really bad. You have an infection in the bone somewhere, and generally we end up being consulted in the hospital after there's perhaps a pressure ulcer that's now gotten into the bone, and now we have to come in and clean out the infection from the bone. And then, of course, then you have to heal the wound on top of that. And so this is completely a team approach to everything where I come in. And then, so infections are the big thing for us. That's generally when we get a call. Additionally, 50% of patients with diabetes will also have arthritis. And that's kind of another reason why we see a lot of patients is osteoarthritis, breakdown of the joint linings and whatnot. And so the thing to keep in mind as you're seeing the different specialists is, how does orthopedics interact with the kidneys, and why does that even matter? Well, a lot of the treatments that we have for arthritis are anti-inflammatories, and so you have to be mindful of what the creatinine is and what the circulation is like, and you don't want to end up with a worse problem. We can always replace your knee, but you can't replace a kidney all the time. So that you have to kind of be very cognizant. Even when you go to the doctor and say, well, can I take this? I'm also taking these other things, or just share the fact that if, hey, well, my kidney function was this, is this going to affect the medication that I'm taking? Because it all really interplays. One of the words that I kept hearing was silent, and, you don't see this, you don't hear this. And, it's exactly right. Sometimes we'll see patients and they come in for leg pain, and it's like, well, we get an x-ray of your knee, and well, it's not your knee, it's not your shin, there's no signs of infection. Well, what is it? Is it circulation? Well, maybe it's circulation, maybe it's peripheral disease of some sort. And so, sometimes on the x-rays, you'll actually see the calcified blood vessels. If you're far enough along, that you'll see that you can almost see where the major vessels are with just an x-ray. So it's not, x-rays aren't just to, as people say, well, it just shows you if something's broken. That's not always the case. If you look at it closely, you can see other things as well. But with orthopedics specifically, again, infections, inflammation, arthritis, those are the big things that we see as a consequence of diabetes. And again, the percentages are very high. And so at some point, maybe 50% of patients with diabetes are going to end up in my office wanting to talk about a knee replacement.
If there is any specific therapeutic approach that you use more in diabetes than other population in the therapeutic options?
So generally when I'm seeing patients for arthritis, again, I always ask, are you diabetic before considering a steroid injection in the knee? Because again, we know that it's going to bump the sugar. And so there's different amounts that you can do. Some people, on non-diabetic patients, I may use a little bit more. And I actually found a long time ago that if you just start everybody on a half a dose, what we call half a dose in orthopedics, 40 milligrams in the knee, you may get a little bump for a day or two, depending on your numbers and how well you control it. And it tends to come right back down. So I always start with the lower dose. That's my therapeutic strategy, and work my way up only as needed, and with monitoring response of the patient. If they had a positive response to a lower dose, why are you going to go with a bigger dose? And also anti-inflammatories as well. I ask them, well, when was the last time you had your kidneys checked? And what was your creatinine? Do you remember? And if everything was okay, then we always try to minimize how much. And I always tell patients, if you don't need it, don't take it.